will be live only.
Right.
Got it.
Okay. Okay. YouTube's go, and we just need to record our Zoom. Cool. All right. Am I good to start? Hello, and welcome to MedNews Week Keynote Conference, where our goal is to bring you the most cutting-edge information from medicine's global leaders. I am Jade Gamble, and I will be your host today. Before we begin, I want to first acknowledge the great team that helps to make these events a reality. Our founders are two internationally recognized researchers, Drs. Jan Leifman and Chandler Park, who is also the president of Kentucky ASCO. Our chairs include Drs. Park and Leifman. Our associate directors include Madhuri Balasubramanian, Muskan Joshi, Garathri Menon, and Helena Coloma. Our managers include Alexandra von de Kieft, William Wilkerson, and Ahmed Aziz. Our educational committee includes Rabed Handad Abbas, Ahmed Hasman Aziz, Blaise Bowers, Harshal Choria, Viviana Cortiana, Jenna Gazel, Sean Jakowicz, Shavika Kanan, Dr. Diksha Manidru, Somia Nadar, Shrey Hasharita, Valabrininia, Imad bin Zahid, Kennedy Itidio, Erika, Adith Baver, Fabiha Amen, and myself. We also want to thank our partners, VU Medi, global leader in medical video educational content, and the National Society of High School Scholars, an honor society founded by Class Nobel of the Nobel Prize family. The moderator for today's event is Muskan Joshi. Now to introduce our keynote speaker, Dr. Gatti-Mays. Dr. Gatti-Mays is the co-director for the Division of Medical Oncology and the section chief of breast medical oncology in the Division of Medical Oncology at the Ohio State University campus in Columbus, Ohio. She is an internationally recognized expert in the field of breast immune oncology. Her research is based in the clinic and focused on tumor immunology and the development of novel immunotherapy approaches for breast cancer using therapeutic cancer vaccines, cytokinins, antibodies, and immune modulators. The recipient of several prestigious awards, such as the Stanley P. Balzarek Distinguished Lecturer Award at the Ohio State University Division of Medical Oncology, among many others. A renowned speaker and panelist who has delivered over 80 keynote presentations globally, and a passionate and dedicated physician who has mentored multiple students in various stages of training. Dr. Gatti-Mays has truly done it all. With that, it is my pleasure to welcome Dr. Gatti-Mays. The floor is yours.
Thank you so much, Jade, for that wonderful introduction. I'm going to go ahead and share my screen here, and we can get started. All right, so as Jade had mentioned, I am the breast medical oncologist with a focus in immunotherapy at The Ohio State University in Columbus, Ohio, and a member of the Pelotonia Institute for Immuno-Oncology. And today, during the breast cancer update, I'm going to be speaking specifically about immunotherapy options for triple-negative breast cancer and be focusing specifically on the neoadjuvant setting. So for disclosures related to this, I have no personal or professional conflicts of interest related to this discussion, no financial disclosures related to this lecture, and I will discuss some non-approved agents or regimens during this lecture and be sure to identify those. So in terms of cancer immunotherapy and recent FDA approvals, we have some settings in the we have some approvals in the early breast cancer setting involving pembrolizumab with chemotherapy, as well as several different options in the metastatic breast cancer setting. The first approval was actually with atezolizumab with chemotherapy, but that has since been withdrawn. And the other combinations are generally with pembrolizumab and chemotherapy or pembrolizumab or dostarlimab as single agent. Now, despite all of these recent approvals within the last few years, when we look specifically in the metastatic setting, and we look at kind of the recent uptake in terms of the use of immunotherapy in patients with general solid tumors, that despite approximately 40% of patients with cancer, advanced cancer being eligible for immunotherapy, only around 12% of patients actually have benefit. And to me, I think that that's always very astonishing. As an immuno-oncologist, obviously immunotherapy has raised extreme life into cancer and oncology and has provided a lot of hope. But it's still only a very small percentage of the patients that I see in my clinic each week that will benefit from immunotherapy. And for those of you who are out there who are maybe not as familiar with the use of immunotherapy in breast cancer, or specifically related to the different regimens and the potential side effects, there are several guidelines out there, but the Society for Immunotherapy of Cancer has the first clinical practice guidelines for the guidance of immunotherapy in breast cancer, and they can be found in the journal as well as on an app for additional information. Now, as I mentioned, the topic of this discussion is really early breast cancer setting, and we're going to focus primarily on the pembrolizumab plus chemotherapy as the different regimens. And why did I choose to focus on that? I think especially when we're considering immunotherapy in solid tumors, I think it's obviously very complicated, as you can kind of see from this schema. Initially, I think we used to really consider it was the breast tumor and perhaps the interaction with the cancer treatment. However, once we start to engage the immune system, patient factors become very much more players than they used to be. And what's also important to remember is that, as we start to appreciate the impact of the tumor and the tumor microenvironment and the immune cells with the tumor and the immune cells with each other, the impact of the cancer treatment on the immune system, as well as those on the patient factors, that search for that single biomarker, I think, becomes even more complex and becomes difficult. And I still don't think we've really found what we've been looking for specifically with that biomarker of effect. Obviously, programmed death ligand 1 or PD-L1 has kind of been really the focus. However, other types of agents or other types of biomarkers like tumor infiltrating lymphocytes, tumor mutational burden, and others is listed here. While they've been interesting, they have not necessarily been a direct biomarker of effect. And so just to focus for a moment on PD-L1 expression, especially in the early breast cancer setting, we see that there's a much higher expression of PD-L1 in primary breast tumors compared to metastatic breast tumors, with primary tumors being PD-L1 positive in about 64% of breast tumors and in metastatic around 40%. And in those tumors that are metastatic, we also see varying PD-L1 expression among the different metastatic sites. However, even with this, the majority of tumors in the metastatic site have a lower expression of PD-L1 than other solid tumors, and definitely lower than their primary counterparts. And so this becomes important because when we think of breast cancer and we think of triple negative breast cancer and kind of these kind of three historically kind of categories of breast cancer being hormone receptor positive, HER2 positive, or triple negative breast cancer, that when we start to look into other types of evaluations of these rather than just through IHC, when we start to look at PAM50 gene signatures, we can start to appreciate that this is a little bit more complicated than just hormone receptor positive, HER2 positive, or triple negative. And then when we start to incorporate some of the other biomarkers that we've really been able to discover uses for over the last decade or so, we understand that it's not quite so simple, and that even within triple negative breast cancer, it's not one type of breast cancer, but rather triple negative is a very heterogeneous group of tumors. And this becomes important because when we start to think about breast cancer statistics and we start to think about the different advances that we've made over the last 10 to 15 years, that still breast cancer is the second most common cause of death in women. And if you're a woman, let's see, sorry, it says recording stopped. The MedNews week moderator. Jade, are you still there?
I am. Let me just get that re-going. I am so sorry.
That's okay.
It looks like I got the YouTube is streaming. Let me get the Zoom recording.
All
Okay,
right,
you should be good to start back.
good. All right, so if you're a woman, your lifetime risk of breast cancer is around 1 in 8. And if you are a man, your risk is about 1 in 833. And when we look at the incidence of breast cancer, And we find that the majority of cases are diagnosed in the early breast cancer setting with only about 5% de novo metastatic or metastatic diagnosis. And the reason why this becomes important is because once a patient has developed metastatic breast cancer, the 5-year survival is still relatively low. And the statistics I have here are from a couple of years ago. But when we look at specifically triple negative breast cancer, there really has not been much of an increase in 5-year survival. It was 11% in this statistic from 2018. More recent statistics have it at about 12%. And so to me, as a clinical breast oncologist with a focus in research, this really highlights the opportunity that we have as researchers to improve outcomes in the patients we see in clinic. Now, in the neoadjuvant setting, so that's chemotherapy prior to surgery, there have obviously been a host of clinical trials that have been conducted that have looked at, can we combine standard chemotherapy with immunotherapy? And as you can see here, the only one that is highlighted in red, which is Keynote 522, that's the only current approval for neoadjuvant chemotherapy and immunotherapy for triple negative breast cancer. But you can see here, there's been quite a few trials, over the years that have shown some very interesting impact on pathologic complete response. And I'll talk about that in just a moment. With a lot of the 3-year event-free survival data still maturing at this time. So let's talk a little bit about neoadjuvant chemotherapy for triple negative breast cancer. So as a breast oncologist, who focuses in triple negative breast cancer, I tend to see a fair number of patients with triple negative breast cancer in my clinic. And when they come in, one of the first things I'll look at is obviously kind of the stage of the tumor, the size of the tumor, lymph node involvement. And for smaller triple negative breast cancers, we are really able to kind of get away with a kind of a lighter regimen of docetaxel and cyclophosphamide, also known as TC, in those patients with maybe 1 to 2 centimeter tumors that are lymph node negative. Sometimes we'll try some adjuvant adriamycin and Cytoxan followed by Taxol. However, in those tumors that are larger and/or involving lymph nodes, so closer to 2 centimeters, lymph node positive, that's really where we start to consider the use of immunotherapy along with chemotherapy. And currently, as I mentioned, the approved regimen is Keynote 522. However, NeoPAC, which I will talk about in a few slides, and while not yet approved, I think is very promising, especially for an anthracycline-free regimen. And so when we're looking at these different regimens, we really focus on the pathologic complete response as a clinical oncologist. And this is because this is a surrogate endpoint for event-free survival in triple negative breast cancer. And obviously it's surrogate, so it's not necessarily always directly correlated, but for the most part, we've seen that those patients who are able to achieve a pathologic complete response or a PCR have better outcomes. They have a lower chance of having a recurrence of their breast cancer. As you can see over here with this bar chart, patients who receive Keynote 522, it's about 65% will have a PCR. In those patients that had NeoPAC, which again is the anthracycline-free regimen with Keytruda or pembrolizumab, it's 58%. And then if we were to use kind of our standard dose-dense ACT in the neoadjuvant setting, it'd be about 40%. And so as you can see here that we have made significant strides over the years with adding additional agents, specifically immunotherapy, in order to get pathologic complete response. But again, this does not benefit all patients. And so when we're thinking of the Keynote regimen, just for those of you who are not familiar, the regimen itself, pembrolizumab, is given once every 3 weeks for a total of 12 months. It can be given generally with Taxol and carboplatin, and then it's followed by usually an anthracycline plus cyclophosphamide. Now, typically in my practice, because of tolerability of the regimen, I've started usually with Taxol and carboplatin as kind of the first initial doses, and I tend to give Taxol weekly for 12 doses, in addition to carboplatin weekly for 12 doses. And then once they complete those 12 weeks of treatment, then they'll go on to get AC, adriamycin, Cytoxan. In the Keynote 522 trial, it's given every 3 weeks, which is not the dose-dense fashion that we typically use. But in the FDA approval, and because of prior data, myself and many of my colleagues actually will opt to give it in the dose-dense fashion that we're typically used to. And when we look at Keynote 522 and we look at some of the baseline demographic data, you can see it was pretty well balanced for premenopausal status, for age. Most of the patients were either stage 2 or stage 3. Stage 1 was not involved in Keynote 522. But when we look at PD-L1 expression in these patients, what was interesting is if you look here, about 80% of the patients in both the chemo and in the Pembro and chemo arm actually were PD-L1 positive. And so this is a little bit higher than typically what we've seen at about 60% with primary tumors. But I think, again, showing that opportunity to engage the immune system early in these patients with these triple-negative breast cancers. Now, Keynote 522 event-free survival data showed at 3 years that the combination of Keytruda with chemotherapy significantly improved event-free survival over just chemotherapy alone, as you can see here. And what was interesting is when the researchers looked at PD-L1 status, even in patients that were PD-L1 negative, the combination of Keytruda with chemotherapy still outperformed chemotherapy by itself. And so in the neoadjuvant setting, the expression of PD-L1 does not seem to be as great of a biomarker of effect. And even those patients that were PD-L1 negative still benefited from Keytruda. And so we don't need to check PD-L1 status in patients when we're considering neoadjuvant chemotherapy with this regimen, which I think is really important. In a lot of these patients, these tumors can be larger, they can be very quickly growing. And so we don't want to delay for checking PD-L1 status as it's not needed for this indication. And the other part that I thought was very interesting is in the supplementary data that was presented with the initial Keynote 522 paper, is the research team looked and found that, in those patients that had a PCR, there really was not much of a difference between those patients who received chemotherapy with Keytruda or just chemotherapy alone. However, even in those patients that did not have a PCR, the addition of pembrolizumab is here in kind of that greenish color, actually did make a bit of a clinical difference, and it was significant. And so again, kind of showing even in where we have maybe suboptimal responses, so it's not a PCR, that there is that benefit to Keytruda. And some more recent data that was presented is related to the residual cancer burden. So because I know that this was a little bit of a mixed kind of audience, I wanted to just take a few minutes to go over the residual cancer burden and the fact that it's prognostic in triple-negative breast cancer. So the residual cancer burden is generally calculated by the pathologist, and it's listed in the synoptic pathology report that you get back at the time of surgery. And essentially, the pathologist looks at the primary tumor bed. They look at the proportion of the primary tumor that's still there that contains invasive carcinoma. It looks at the number of positive lymph nodes that were there, and then the diameter of the largest nodal metastasis. And basically, they come up with it's a score of 0, which is a pathologic complete response, up to 3. And studies have shown that this residual cancer burden in triple-negative breast cancer, as well as HER2, which is beyond the scope of this talk, but is associated with event-free survival as well as distant relapse-free survival in patients with triple-negative breast cancer. So the higher the RCB score, kind of the higher the chance of having a recurrence of the breast cancer. And again, we know that it's prognostic. This is kind of to give a little bit more kind of some numbers. This was a larger study and looked in patients, and you can see here those that had an RCB 0, which is a PCR, their risk of recurrence or 10-year relapse rate was 86%. And those patients that had an RCB 3, so had quite a bit of tumor left after the completion of neoadjuvant chemo, their 10-year relapse rate, their event-free survival is down at 23%. And I'm always very, kind of taken aback when I look at kind of that first 2-year interval where you can see a marked drop off in the Kaplan-Meier curve, that these patients with the residual cancer burdens of 3 have a very high risk of recurring rapidly. And I think for all of us to take care of breast cancer patients, we've all seen those patients, unfortunately, in our clinic. And so when we have residual cancer after neoadjuvant chemotherapy, our standard of care for quite some time now has been the addition of adjuvant capecitabine based upon the CREATE-X study. Capecitabine is given for 14 days in a row with 7 days off, and typically given 6 to 8 cycles. And in the CREATE-X study, they found that there was an improvement in disease-free survival as well as in overall survival in patients with triple-negative breast cancer who received adjuvant capecitabine. And to me, I think that looking at kind of what we did prior to Keynote and prior to using pembrolizumab and trying to reconcile it with now the use of Keytruda, sometimes we end up with some data-free zones. And so in patients who have triple-negative breast cancer, who receive neoadjuvant Keynote 522, which is the pembrolizumab and chemotherapy, and then have residual disease, we're still not quite sure exactly how best to treat these patients. And in the NCCN guidelines, there was a statement that was added recently, I think a version or two ago, specifically stating the fact that there's no data on sequencing or combining adjuvant capecitabine and pembrolizumab or olaparib if they had a germline mutation. And basically, we can consider their sequential or combined use, typically in patients that have residual cancer after neoadjuvant chemotherapy. I'll talk to them about the fact that this is a little bit of a data-free zone. However, we have good safety data, and so often I will combine the capecitabine along with Keytruda, acknowledging the fact, though, that this is a gray area and data is definitely needed. And again, when we look at residual cancer burden and Keynote regimen, this data actually just came out within the last month, specifically looking at the RCB status for this regimen. Now, I think, initially, many of us kind of were questioning, well, how impactful is the residual cancer burden with patients who have this Keynote 522 regimen, just because obviously it had not really been validated at that point. But some of the more recent data, again, that came out of the study that was just published, as you can see here, in patients that have an RCB 0, again, their event-free survival is relatively good and comparable, if maybe not a little bit better than what we've seen in some of the other studies. RCB 1, again, there's not a huge difference between those that got Keytruda and those that didn't. But once we get to RCB 2 and RCB 3, you can see that there's more of a difference, and specifically in patients with an RCB 2, where that addition of Keytruda did make a significant impact in reducing kind of the risk of recurrence and improving that event-free survival. However, in patients with an RCB of 3, some would argue that there's not a huge difference between the patients that got Keytruda and chemo versus those that just got Keytruda. And actually, if you look, it looks like the lines are inverted with those patients who with an RCB 3 who received chemo only actually did a little bit better. And what was also very interesting in this paper that just came out is when the researchers looked at the site of first recurrence, they actually found that there was probably a little bit more perhaps of brain metastasis only recurrences than what were being expected. And specifically, if you look in those patients that had those lower RCB rates, so in patients that had RCB 0 or a PCR, risk of recurrence for brain met only is about 1.75% of those patients that had the recurrence. And then for RCB1, you can see actually that's quite a high number in those patients, nearing a little bit more than 4% had brain metastasis only as the first site of recurrence. And to me, this actually I found somewhat disturbing because, again, in these patients that have RCB1, looking at this data, looking at even some of the data from the CREATE-X trial, some physicians may not necessarily offer adjuvant Xeloda for patients with RCB1. And after this data came out, there was several discussions with colleagues, and I think I've also seen on social media and saying, well, this is even more reason, obviously, for patients with RCB1s after Keynote to get adjuvant capecitabine. And to me, I thought that, with looking at the data, when we look at not only capecitabine, but other other regimens, including this Keynote 522 regimen, that often the report of brain metastases are relatively low or not necessarily focused on. And so I give a lot of credit to to the physicians and the scientists on Keynote 522. And what's interesting is in these patients with triple negative breast cancer, about up to 45% of patients with triple negative will develop brain cancer metastases over their lifetime. However, in many of the clinical trials that have led to these immunotherapy approvals in the metastatic setting, which again is not what we've talked about so far, only a very small percentage of patients that were included in the trial led to the approvals for immune checkpoint inhibitors. And so this leaves me wondering, not only from an immunotherapy perspective, how effective is pembrolizumab in brain metastases in patients with breast cancer, but also in the setting of when looking at data like this, where we see great responses. We see an RCB0, RCB1, and we're still having brain metastases. And to me, this is kind of this is kind of opposite of what we've typically been taught, where if you have good systemic control, your risk of brain metastasis is lower. And so, again, I think we're trying to figure out in patients as we're maybe doing better for treatments, how are we able to kind of parse out some of those patients that are higher risk versus maybe those that are not. Circulating tumor DNA or ctDNA, I think right now is a really exciting type of technology. This is basically detectable cell-free circulating tumor DNA. They're small pieces of tumor DNA found in the peripheral blood of patients with cancer, as you can see here. And what's been really interesting, there's been a lot of really nice work. Some of the work has come out of Heather Parsons' lab, looking at CT dynamics, so changes in ctDNA during neoadjuvant chemotherapy. And what Dr. Parsons was able to find that in those patients who between week 0, week 3, and week 12, those patients that had a nice decrease in ctDNA were more likely to be responders. And so again, I think that that's an interesting kind of observation. And Dr. Parsons is not the only one that has found that. Other investigators have also found that as well. And in addition to the dynamic changes of ctDNA during neoadjuvant chemotherapy, several investigators have also found that in those patients that have persistent ctDNA after the completion of neoadjuvant chemotherapy, that these patients have worse outcomes among all breast cancer subtypes. And in this specific study by Stecklin in MPJ breast, in those patients, when they actually looked at ctDNA and they correlated it to the different RCB status, as you can see here, that there was a further kind of categorization of those patients, perhaps that were ultra high risk for recurrence. So if you look here, both in panel A and panel B, panel A is event-free survival, panel B is overall survival, that in those patients that had an RCB2 or an RCB3, which RCB2 is the dotted line, RCB3 are the solid lines, they were able to kind of parse those out based upon whether there was the presence or absence of ctDNA. And those patients that had an RCB2 or 3 with positive ctDNA did much worse and had a lower event-free survival and lower all survival than those patients that had an RCB2 or 3 with a negative ctDNA at the completion of chemotherapy. And so one of the questions I find that we still very much need to answer is, if we know that patients with residual disease after neoadjuvant chemotherapy do worse, what can we do better? How can we change the treatments? And so right now, our current standard of care for residual disease, as I mentioned, is adjuvant pembrolizumab. So patients will continue pembrolizumab after they complete the chemotherapy of Keynote. They continue the pembro through surgery, through radiation, and to complete the full the full year of therapy. Pembrolizumab is given during radiation. And then typically after the completion of radiation, if patients have a germline mutation, we would consider adding on adjuvant olaparib. Or if they did not have a BRCA mutation, we would consider adding on adjuvant capecitabine for the CREATE-X trial. And again, to me, often when I counsel patients, I'll talk to them about there's limited efficacy data on either of these combinations of pembro with either olaparib or capecitabine in the adjuvant, and really even in the metastatic setting. But we do know that the combinations are safe, and this has been established in metastatic breast and other solid tumors. However, we do not know at this point, does the combination improve outcomes over either adjuvant capecitabine or olaparib alone? And we don't really know, does adjuvant olaparib or capecitabine reduce the risk of CNS recurrence? And to me, these are, again, two other questions that I think as we move forward and are using Keynote 522 regimens or like regimens in our patients, that we really need to pay attention to these questions. One of the studies that I think really has nicely addressed this and is starting to look at perhaps some of the changes is the OXAL study. This was done by Philippa Lynch up at Dana-Farber. And in this study, patients received neoadjuvant chemotherapy, they went to surgery, and if they had residual cancer, they were randomized to either nivolumab by itself, capecitabine by itself, or nivolumab and capecitabine. And Dr. Lentz was able to look at the peripheral immunoscore, and basically those patients that had a higher score, it indicated higher immune activation. And what Dr. Lynch was able to see that in patients when it was either before, so kind of at the baseline, or kind of during the treatment, you can see here that they did see some differences in terms of the regimen, whether it was nivolumab, capecitabine, or the combination, with really kind of when they, due to smaller numbers, they combined the combination of those patients that had nivolumab and then nivolumab or capecitabine. Basically, the addition of the immunotherapy agent did improve or kind of increase the immunoscore from pre to post. The primary endpoint of the trial, again, they met that with showing that there was an increase in peripheral immunoscore. But the secondary endpoints, there was no increase in toxicity or IRAEs with the combination of nivolumab and capecitabine. They had a median invasive disease-free survival that was longer in the combination, but it was not significant. Again, these numbers were relatively small, about 15 patients per arm. And again, the median 2-year invasive disease-free survival also was a little bit longer, but not significant. And so, aside from understanding some of the peripheral immune changes that occur with the addition of these adjuvant therapy agents, another area that I found very exciting and very interesting is perhaps that in those patients maybe that have that residual tumor, is there something that we can do to that tumor, perhaps before it's removed at the time of surgery, to really stimulate the immune system? And so cryoablation is one of the possible techniques. This is, you have a breast cancer cell here, and you can see that it's somewhat immunologically cold. We're, not really able to get, various immune cells to infiltrate the breast cancer, which is pretty typical. Cryoablation is a procedure very similar to a breast biopsy where a probe is placed into the tumor. And with the cryoablation procedure, there's short intervals of extremely cold temperatures to freeze and thaw the tumor and the surrounding tissues. This causes necrosis and then results in local inflammatory response. And what's interesting with cryoablation is you get release of intact tumor antigens, cellular stress antigens, and immunocytokines. So it's really kind of a nice way to stimulate the immune system. And again, with the fact that when we have perhaps that immune stimulation, if we can use an immunotherapy agent like Keytruda in combination with that, perhaps we may cause a cold tumor to become hot. And so Dr. Heather MacArthur at UT Southwestern had previously done a really nice study of a preoperative single-dose ipilimumab and/or cryoablation. And in these, again, this was a relatively small pilot study of just 6 patients in kind of each arm, either cryo, ipi, or the combination of cryo and ipi together. And it was a feasibility study. It had a acceptable safety profile. There were no delays in curative surgery. But what was interesting, and Dr. MacArthur had recently published some of these results, is that at the 66-month follow-up, all of the 18 patients that were in the trial were free from recurrence, including 3 patients with triple-negative breast cancer. So this is past that 5-year mark. And when Dr. MacArthur also looked at some of the exploratory endpoints, found that there was a very nice increase in activated CD4 and CD8 T cells, as well as an increase in interferon gamma, IL-5, and IL-10. And so based upon the study, Dr. MacArthur is now doing a perioperative immunotherapy and cryoablation trial. So in those patients who now are receiving pembrolizumab as part of Keynote 522, and if they have residual tumor, either identified on imaging or exam, the patients are eligible for cryoablation. And so far, no delays to surgery in the initial patients. The clinical evaluation is ongoing. And this is a trial that we have open at Ohio State. And again, I think is just really exciting, looking at different ways perhaps that we can help stimulate the immune system, given the fact that we know we've got maybe about 80% of patients in the neoadjuvant setting with PD-L1 positivity in their breast tumor. And again, in those patients perhaps that did not have a pathologic complete response, maybe those are identifying some of the colder or more immunologically kind of ignorant or suppressed tumors. And perhaps a therapy like cryoablation may really be able to synergize with Keytruda while the tumor is still within the breast prior to surgery. In addition to this, I think there's also some other really exciting trials for patients with residual disease. one of which is the ASCENT-05 or Optimize-RD trial. This is a phase 3 trial with Dr. Tolaney as the study PI. It's about a little bit more than 1,500 patients and open to patients with stage 2 or stage 3 triple negative breast cancer with residual disease after neoadjuvant chemoimmunotherapy. Patients are either randomized to sacituzumab govitecan with pembrolizumab or investigator's choice, which is pembrolizumab or capecitabine plus pembrolizumab. Another trial I think that is really exciting for those patients with residual disease is Treponium-Breast03, which is a phase 3, has a little bit more than 1,000 patients, and this is for patients with stage 1 to 3 triple negative who receive neoadjuvant chemoimmunotherapy and have residual disease. Treponium-Breast is looking at the combination of datopotamab deruxtecan with durvalumab versus datopotamab deruxtecan versus investigator's choice. And again, as you'll see here, it's capecitabine or pembrolizumab or the combination of capecitabine and pembrolizumab. And so both of these trials are comparing their investigational arm to our standard of care, which again is either Keytruda with or without the capecitabine. And so I think obviously many of us have had experience with sacituzumab, specifically in the metastatic breast cancer setting. And I've had some very nice kind of anecdotal patient responses in patients who have had very resistant chemotherapy or very chemo-resistant tumors. And so I'm excited to see the Optimize-RD data kind of as it comes out over the next few years and as patients are enrolled. However, with Treponium-Breast, I think a lot of people have, who are maybe not familiar with datopotamab are wondering some of the background kind of behind this. And I can't help but think at least that, some of the data really needed to, or probably came from the very promising results from the Begonia Arm 7 trial in which datopotamab deruxtecan was combined with durvalumab. And this is an unresectable first-line triple-negative breast cancer. Datopotamab deruxtecan is an antibody drug conjugate that's a TROP2 antibody with a topo-1 inhibitor payload. And in this study that was presented at San Antonio back in 2022 by Peter Schmid, saw a really nice kind of confirmed response rate. So of their patients that were enrolled, it was about 74% with a couple of complete responses and partial responses. As you can see here from the spider plot, we saw some very nice durable responses with this. And again, what was really interesting, I think, about this data is when the investigators looked at those tumors that were PD-L1 positive or negative, it didn't really seem that the activity of this combination depended on PD-L1 status. So in these patients that have residual disease after chemo and immunotherapy, I'm excited to see and to enroll patients on these trials and to see kind of over the next few years, perhaps how we can improve some of the outcomes. Now, in those patients that did receive chemoimmunotherapy and then had a pathologic complete response, I think one of the other questions that comes up is, do we really need to continue the pembrolizumab in the adjuvant setting? And so at this point, we have no data to say that we don't, but as we all know, Keytruda not only comes with financial toxicity for a lot of patients, there's also some toxicity that's associated with development of immune-related adverse events. Even though this is more common during the neoadjuvant portion of the treatment, we all know immune-related adverse events can occur at any time during immunotherapy treatment, as well as even after the completion of immunotherapy treatment. So Dr. Tolaney is also PI on the Optimize PCR, where they'll be looking at whether or not adjuvant pembrolizumab is needed. And looking at a recurrence-free survival in those patients who achieve a PCR, as well as various secondary objectives like quality of life, overall survival, and some correlatives. And so again, if we know that patients with a PCR after neoadjuvant chemotherapy do better, can we de-escalate treatment? Related to de-escalation, I think the other type of chemotherapy, or with our chemotherapy regimens, one of the concerns is use of anthracyclines. And so we've all seen, obviously, patients that end up with long-term cardiac issues as well as MDS or leukemias as a result of anthracycline use. And so there have been several attempts to find, is there an anthracycline-free regimen that can be used along with immunotherapy? And so the NeoPAC study, which was published back in December, looked at carboplatin, docetaxel, and pembrolizumab. So this is an anthracycline-free regimen. in patients with stage 1 to stage 3 triple negative breast cancer. Now, this was a single arm phase 2 study. This regimen is not yet approved, as I have up here. But what was interesting is when they looked at the PCR rate, they had about 58%, which again, not that we would compare with Keynote 522, because we won't compare across trials. But in Keynote 522, pathologic complete response rate is about 65%. And in NeoPAC, you can see that in those patients that were node negative, we actually saw a nice PCR within the breast as well. And in this regimen, they also looked at a little bit higher ERPR of up to 10%, and again, saw still a very nice pathologic complete response rate. They also reported some of their 3-year event-free survival, and so in those patients that had a PCR, 98%, and overall in their population, it was 86%, but again, those with residual disease down at 68%. And so again, not that we would ever directly compare two trials, but in looking at this, our PCR rates again are somewhat similar. And when we look at the 3-year event-free survival, it does again look relatively comparable, although of course noting that Keynote 522 was primarily stage 2 and stage 3, whereas this also allowed, or NeoPAC allowed stage 1 triple negative breast cancer as well. So Keynote 522 was a slightly different patient population, but nonetheless does seem obviously intriguing. Perhaps maybe we can get away with out an anthracycline. And I think that this is, even though it's not necessarily approved at this point, is a potentially a viable regimen for those patients where we can't use anthracyclines, but still want to make sure that they're able to receive immunotherapy. And so in summary, I think, we've come a long way in terms of neoadjuvant chemoimmunotherapy. It's currently standard of care for anybody with a triple negative breast cancer that's greater than 2 centimeters and/or involves a lymph node. Right now, our current regimen is Keynote 522, which is pembrolizumab plus chemotherapy. NeoPAC, though, I have a question mark here because it's not officially approved yet. But I think, even though it's a small single-arm phase 2 study, I think, again, it's very promising in the data that they've presented to date. And it potentially is a viable option for those patients where we can't use anthracycline. However, in patients where anthracycline can be used safely, I still would prefer Keynote 522. For the next point, residual disease after neoadjuvant chemotherapy carries a worse prognosis. And again, we've known this for quite some time. Right now, the residual cancer burden status is the current estimator, but limitations exist. And so again, looking at the Keynote data that just came out a couple of weeks ago, even in those patients with an RCB of 0, so a PCR or 1, we can't necessarily, we can't relax to the point of saying, oh, their chance of recurrence is so low, specifically in those RCB1 patients, maybe they don't need the adjuvant Xeloda. I think that data that was just presented or that was just released from Keynote 522 authors, I think for me has really reinforced the fact that even in the setting of residual cancer burden of 1, I would offer adjuvant Xeloda for these patients. In terms of residual disease, those that have a positive ctDNA after neoadjuvant chemotherapy, it indicates a worse prognosis. However, when I talk to many of my patients about whether or not we check the ctDNA as part of clinical care, currently I do not, because right now, if we have a patient that does have a positive ctDNA, we're not quite sure how to use that information, or even if potentially we can improve outcomes by acting upon that information. And the optimal regimen for those patients with residual disease, whether it's in the breast or axilla, or whether it's in the blood through a positive ctDNA, is really unknown at this point. Our current standard of care is either pembrolizumab plus or minus capecitabine or olaparib. And the optimal regimen for those with a PCR is unknown as well. So again, is there potential to de-escalate care? And so these are really my remaining questions, specifically for the treatment of triple negative breast cancer in the neoadjuvant setting. So 1, does a change in neoadjuvant or adjuvant therapy improve outcomes, specifically in those patients with residual tumor either in the breast or in the blood? And so again, our standard of care right now is the pembrolizumab with capecitabine or olaparib. There's several clinical trials that are looking at acting upon and changing the adjuvant therapy. So an optimized changing it again to sacituzumab plus pembrolizumab or troponin, breast 3, changing from or changing to datopotamab deruxtecan with durvalumab, or potentially can we use cryoablation for when the tumor's still within the breast to help improve outcomes in the immune response? Second question is, are there better biomarkers to use during therapy and after completion to guide a change in therapy, which would improve outcomes? So looking at more data for ctDNA dynamics. So, or if we can change how quickly the ctDNA clears, or if we can change that it clears, does that perhaps improve outcomes? And if it doesn't clear, does that mean that we should change to a different therapy regimen? At this point, I would not make any changes based upon ctDNA, but I think these are helpful questions for us to think about as clinical researchers. And is there potential to use ctDNA along with residual cancer burden and perhaps find some of those patients that are ultra high risk? That leads me to question number 3. If we can identify these patients with ultra high risk, are we able to intervene? So can we identify those patients with a higher risk for rapid recurrence? Maybe perhaps those at risk for brain metastasis development, as these both can be catastrophic events for a patient. And then finally, is there a group of patients that we can perhaps de-escalate therapy? Maybe patients with a PCR, are we able to change the regimens, and others to have a non-anthracycline regimen? And for me, these are questions that I hope that we'll maybe be a little bit closer to answering within the next 5 to 10 years. But I'm very hopeful when I look back over how far we've come, that I think we'll be able to get to the answers of some of these questions. And so with that, I thank you for your attention and see what questions you have.
Thank you so much for such a wonderful presentation, Dr. Gatti-Mays. I know I certainly learned a lot, and now to begin that Q&A portion, I will be passing it over to our moderator, Muskan.
Thank you so much for the amazing presentation, Dr. Gatti-Mays. So as noted and as seen from our audience members, they have a lot of questions. So we will now be proceeding with our Q&A portion of our keynote session. So for the very first question, I would like to ask something. So given the perspective about the anti-breast cancer vaccine, I would like to really know about your perspective over the anti-breast cancer vaccine, given that we have recently ran a positive clinical trial and seen our success with melanoma. So I would love to hear your perspective over it.
So I guess so for the anti-breast cancer vaccine, do you mean the ones that they've talked about kind of in the adjuvant setting? So to prevent the development of breast cancer, to prevent the recurrence, because there have been several different trials looking at vaccines. So
I honestly would just love to hear your perspective over the prevention and also for the treatment aspect.
Okay. So I think, I've done quite a bit of work with therapeutic cancer vaccines prior to my time at The Ohio State when I was at the National Cancer Institute. And I think the vaccines, vaccines in general, I think tend to work a little bit better when there's lower volume of tumor. And so I think, especially in the vaccines that we've seen so far, I think some of them are promising, although none of them have necessarily generated the robust immune response that we were hoping for, and nothing has necessarily directly shown in breast cancer that it does significantly reduce that risk of developing a recurrence. However, I do think kind of in those patients, perhaps that are that ultra high risk, to me, that's really the location I think that I could foresee perhaps a therapy or a kind of a breast cancer vaccine kind of being the most useful of those, perhaps the ones that are rapid recurs, things that we can stimulate the immune system. But to date, so far, I mean, we've seen some promise, but nothing necessarily, I think that's really kind of developed significantly.
That's interesting to hear. And thank you so much for your perspective, Dr. Gatti-Mays. So for the next question, I'll be passing over the mic to Jade.
All right. So I just wanted to ask, so how can artificial intelligence be effectively utilized for risk stratification in that triple negative breast cancer patients? And what are the potential implications for personalized treatment approaches and clinical outcomes if we were to implement AI?
Yeah. So I think AI, right now there's definitely been a lot of discussion about AIs in terms of the use of mammograms, and obviously are we able to detect a little bit sooner sooner with some of these patients. I think with triple negative breast cancer, many, although not all, have very high proliferation rates. And so I've seen quite a few patients where, we'll describe the mass tends to grow overnight. They'll notice it within a couple of weeks. It tends to be a little bit higher kind of growth kinetics than some of our other tumor types. That being said, I think, a lot of times they do end up, maybe, patients had a mammogram 6 months ago, wasn't seen, and now they feel a mass. And so I think there always is that question of, was that tumor there? We just couldn't see it. And so I do think from that AI perspective, maybe we might be able to tell some of these smaller clusters of cells perhaps before they start to grow. And I think that would be very exciting, especially as a physician who sees a lot of patients with large triple negative breast cancers. But I think, from my perspective, the AI approach for mammograms, I actually am very excited to see the potential of how it may impact actually a lobular breast cancer phenotype. Which is one that's often missed on mammograms because of very subtle differences or distinctions for the radiologist to view. In terms of kind of AI, kind of more broadly, I do think that there's a lot of interest potentially in using AI are we able to analyze the makeup of the tumor, the mutational status, and perhaps find that Achilles heel? So more from like an analytic AI perspective. And again, I think that there's some interesting data with it. I think, again, I feel like we still need to learn a lot about, perhaps kind of that, some of just the general makeup of the tumor. But I think obviously the AI has that potential to really help us understand not only the tumor microenvironment, but the interactions with the surrounding immune cells. And so again, I think that, AI is definitely one of those fields. I think probably in the next 5 to 10 years, I'm hopeful to see a lot of positive things out from it. And specifically for tumor types like triple negative, where we obviously need better treatments.
Definitely. I'm super excited to see the entire perspective and how AI is implemented, especially in the field of oncology. And I've also read many different studies where they discussed and showed that the combined power of an AI and a radiologist had the most highest sensitivity and specificity for diagnosis of various different types of breast cancers. So I don't think AI is here to replace us. I think AI is here to augment us in the best possible way. So I'm extremely happy to hear your perspective on this. So for the next question, I'll be passing over the mic to Adib.
All right, thank you. So I was just another question, like everything you've been saying is really interesting. And what are you most hopeful for in the field of triple negative breast cancer and how it can, what are some research in the future that's gonna, benefit all the practitioners?
Sure. So I think for me, one of the areas of triple negative that I'm most hopeful about is, probably one of the first slides that I pointed to in this presentation is, only about 5 to 8% of all breast cancers are diagnosed metastatic at the start. And so to me, as an oncologist, that says we have a huge opportunity to identify patients early on, maybe at higher risk, and perhaps intervene. And again, I think from an immunotherapy perspective, the smaller the tumor, I think, the better the opportunity for the immune system to really get control of those cells. And so for me, as a physician scientist, as a patient or as a physician who sees these patients in my clinic all the time, that's the part that I'm most hopeful for, is that over the next 10 years, we'll be able to identify, okay, of those patients that are maybe at higher risk of recurrence, what can we do to intervene? How can we better utilize the immune system and the immunotherapy options that we have so we reduce that risk of recurrence? And I've even seen, just in my time of being an oncologist, a little bit more than a decade since deciding to go in oncology, there's been this tremendous improvement in how patients with triple negative do. And so when I first started thinking about doing breast oncology, when I would talk to my patients about triple negative, if I was to give this talk, it would be about a 5-minute talk. And I find that it's really exciting when I think of all these options that have occurred just over the last 10 years, where now when I see patients with triple negative breast cancer, even in the metastatic setting in my clinic, it's a much longer discussion than it was. And so my hope is that some of that will now translate to that neoadjuvant setting or the adjuvant setting, so we can even reduce that chance of them developing, metastatic cancer to start with.
Thank you for that wonderful answer, Dr. Gatti-Mays. And surely, I think this is such a huge avenue to explore, and I truly hope this is the future that we set into. So, for the next question from our audience members, what is the future of cell therapies for breast cancer given recent advances in blood cancers?
Yeah.
What are we with this, and when do you feel that cell therapy will make their way as a breast cancer therapy?
Sure. So from a cell therapy perspective, I think there's tremendous potential. That's actually one of my areas of interest in immunotherapy. I think CAR T cells have been really interesting, but you need a good target. And so that's one of the limitations, I think, when it comes to a lot of solid tumors like breast cancer, is we don't necessarily have kind of pure tumor antigens, meaning they're not necessarily expressed across all breast cancer subtypes or even among all breast cancer cells in a patient. However, there are other cellular therapy types. Dendritic cell vaccine, Dr. Nora Desis has done tremendous work with dendritic cell vaccines, and I think that's a very hopeful area of cell therapy for breast cancer. Dr. Steve Rosenberg has done also some great work with TIL therapy, and there's quite a bit of interest in being generated for triple-negative breast cancer. But the other cell therapy type that I personally am interested in are natural killer cells. And so I have a clinical trial that's open at Ohio State right now using donor natural killer cells that have been modified to be resistant to a immunocytokine called transforming growth factor beta. And I think these natural killer cells, we know that they're an important part of the innate immune system, and they're part of what helps us keep breast cancer away. And so when the tumor cells inactivate them, we're kind of at a disadvantage. And that's one of the reasons the tumors are able to grow and propagate. And so from a cell therapy perspective, I am extremely interested to see how natural killer cells kind of unfold in breast cancer treatment. But I think all of the cell therapies that I mentioned have promise. And I think we're still very at the early stage of those cell therapies in breast cancer. And so looking forward also to where that goes in the next, 5-10 years.
I think that's what I truly love about therapies, especially in oncology, how everything ends up, even if it doesn't look like it, therapies do overlap, and how we can use the potentials of one therapy in certain field in oncology and incorporate it into the other. And I think that's the beauty of oncology, right? So,
Absolutely.
another question from our audience member. What, according to you, are various different socioeconomic barriers that currently hinder access to timely diagnosis and optimal treatment for TNBC patients? And what strategies do you think can be implemented to address these challenges and ensure an equitable care delivery?
Sure. So I think that's a great question. So, triple negative breast cancer does tend to occur in a higher population of African American women. And so obviously, I think there is a health disparity kind of issue to it in the sense that, lower mammogram uptake in some cases. But I think even, out here in Columbus, I've also been surprised with just the number of patients from rural communities that come in with large triple negative breast cancers that didn't have access to mammograms. And so as someone who sees a lot of young patients, probably a third of my patients that I see in my clinic are probably 40 and under. So definitely a younger population. And a lot of them have triple negative breast cancer. These are a lot of patients that probably never would have had, like they weren't due for their mammograms yet. And so I do think that it's, from a health disparity issue, I think a lot of times when I see patients that come in with larger triple negative, it's because the mass has been present. They didn't know where to go. They didn't have a mammogram location that they knew they could go to. But I think even from the perspective of the treatment regimens that we use, I think, when we see advances in clinical treatments like we did with Keynote, I always go back to look at kind of the demographic tables. And so looking, are we having a patient population in the clinical trial that's comparable to the patients that I see in my clinic? And I think for the most part, most of us say that the clinical trial populations do not mirror those patients that we see. And so I think, increasing access or just awareness of where patients can go for imaging if they find a breast abnormality, I think is key. I think improving access to clinical trials, I think is key in terms of improving outcomes for our patients. And just also too, in terms of, a lot of times when it comes to, triple negative breast cancer, because of the fact that it tends to be, kind of faster growing, it tends to sometimes be an inflammatory appearance, so can involve some redness of the breast and some swelling. I have noticed that a lot of times patients are written off by their physicians or their emergency room docs because, again, in the vast majority of cases, that redness of the breast, the swelling, is not cancer. And of course, I recognize that I see the part that's skewed the other way, that it's all cancer. But I think when it comes to kind of later detection in later stages, specifically in patients that are, kind of underrepresented, one of the things I always tell patients, the best things they can do is to be their advocate. So if they're noticing breast changes, while it's scary, to kind of, keep acknowledging the fact that these changes are there, and to get in to see the doctor, to make sure they know that this is not normal. And sometimes, again, that's they're given the knowledge then of where to go for those mammograms, where to go for the imaging.
Thank you for that wonderful answer, Dr. Gatti-Mays. And I think everything you said right there was so important. And that's the difference in ensuring that the patients that do come to you are not like, because I have seen a handful of cases where people just diagnose themselves with breast cancer and come to you, versus a patient who actually has a certain issue, and when to know when you need the proper medical intervention. I think what you said is so important. And even like when you spoke about the socioeconomic differences, especially in African American women who come to you from rural areas, and how the outcomes are worse, everything you said it holds so much truth. And I truly hope that we are able to pave the way of healthcare to lower socioeconomic areas and areas of disadvantage, and also ways different lower socioeconomic countries, because I certainly do believe that the US has the best access to healthcare compared to lots of parts of the world. So hopefully we can pay the way.
Yeah, and I think to your point there, kind of, even just internationally, I think, a lot of obviously the data that I presented today is all from the US in terms of access to these agents. And I think, that de-escalation question, I think, becomes especially important to, do we really need a full year of Keytruda in those patients that have a PCR? Right? I mean, when we think of that financial strain, when we think of those resources that are needed, not only to the cost of the agent, but for the patient to take off time that day to get to the clinic, to get the infusion, to get the labs. I think as we push forward in oncology and we improve outcomes, I think it's also important to look back and say, okay, do we really need all of this? Is there a way that we can de-escalate safely so that we make that this regimen is more accessible to more patients? Because I think that that's one of the things that's very challenging is, we have sometimes these great regimens, but the majority of patients don't have access to them. And so it's always important as researchers, not only to look forward about the next big thing, how are we going to improve outcomes, but to take that time to look back and say, okay, how can we pare it down?
Definitely. I think all the points and all the questions and all the concerns that you just raised are not just important for clinicians, but also for scientists and researchers in this field. So for our next question, Helena asks, as a mentor yourself, how has mentorship helped you in your career, and what advice do you pass on to your mentees?
Sure. So yeah, so mentoring, I think, has been extremely important for me. I've been very lucky to have some incredible mentors kind of in my career so far. And, I think probably the most important advice one of my mentors actually back in college gave me when I didn't quite know what I wanted to do, she said, just follow what makes you happy. She was like, just pick what you want to do that makes you happy, that makes you excited, that makes you want to stay up late and read a paper. And that was one of those pieces of advice that kind of stuck with me, and my path to where I am now has definitely not been a straight path. There have been a few deviations along the way, and they were good deviations, definitely ones that I needed to have to help get me to where I am now. But I think that advice was really important. And so whenever I have mentees, I always tell them that as well, of, you don't necessarily have to know what you want to do with your life. You just have to know what interests you, what excites you, and that's what you follow. And I think in terms of mentorship, I think one of the best things about mentorship in my experience, and one of the things that I again feel that I've been lucky to experience, is that my mentors have pushed me sometimes beyond what I felt that I was capable of doing. And I think sometimes as a mentee, that's terrifying, because you're like, why are they being so hard on me? Why are they pushing me so much? And then in retrospect, it's because, well, obviously they felt that I could do it. They believed that I could do this. And I think that's the important part of being a mentor, about being a peer mentor, even with your friends, your colleagues, is, you need to be each other's cheerleaders. You need to lift each other up. You need to be reasonable. But you also need to make sure that people realize that sometimes they're greater, that they can do things more than what they think they can. That imposter syndrome is real. And so making sure you surround yourself with some good truth tellers to keep you balanced, but also some good cheerleaders too.
Definitely. I think the relationship between a mentor and a mentee is one of the most important relationships you can have while in training. And understand and to have someone who can acknowledge and help you realize your limits is a privilege that not many have. So thank you for your answer, and thank you for that wonderful answer. It really resonated with me, and hearing you and seeing you at this stage really made me realize, makes me think like a mentor is so important, and truly
Absolutely.
everything you said was so true. So for our very last question, for our more junior attendees who are just getting into research and medicine, what has inspired you to pursue this field, and how has this choice impacted your life? Has it been
Sure.
everything that you initially anticipated? We would love to hear your perspective on.
Sure. So I think, it's to kind of think about that question. I think I need to go back to, before I decided I even wanted to be a doctor. And, in thinking before I get to med school, what I wanted to do with my life. And if you asked me at that point, would I be an oncologist? I would have said, no, that's not what I want to do with my life. And so, along the path, the path in medical school and getting into medical school, again, it was kind of following those things that made me happy, that made me want to do more, that made me want to learn more. And I think that's the same in terms of doing what I do now. So as a breast cancer oncologist, I see 50 to 60 patients in my clinic per week. And I see a lot of triple negative breast cancer. And it is without a doubt that it's my patients that inspire me on a daily basis to do the research that I want to do, to plan for the next study, to look at the tumor microenvironment. It's the patients that I see all the time that inspire me, and that make us as physicians we have to push better. We have to do better. We have to push harder and further with our treatments. And we have to acknowledge the fact that all of the treatments are for our patients. I think that's one of the things that I love about being a physician scientist, of seeing patients and doing research, is I have faces to the patients, names to the patients that inspire me. And so it makes me think of, not only is this treatment going to make them live longer, is it going to maybe help them see that, child graduate from college, but it also helps me remember, okay, I've got to think about toxicity. I've got to think about, how is this going to impact their quality of life? Are they going to be able to enjoy seeing that child graduate from college? And to me, those are the things that, as a physician scientist, I think make it all worth it, is when you get to see the patients do better, you get to enjoy what you're doing. And it's a special type of job that we have in oncology. I think, it's not all days are easy, but I think they're all great days because of the people that we're surrounded with, not only from our patients, but the people that we work with as well.
I think it's truly so refreshing to hear your perspective and to hear someone speak about their field and their work in such a way that you just did. Because I truly feel that in medicine and in the hush and the rush of everything, you tend to lose track of what exactly we are here for. So hearing you speak about this at the point that you are today, after everything that you have been, is so refreshing and extremely grounding. And I'm so grateful to have heard this amazing piece of advice and this amazing piece of words from someone such as you. So thank you so much, Dr. Margaret.
Mhm,
I'll be passing
mhm.
over the mic to Jade now for our final concluding remarks.
Great.
Thank you again, Dr. Gatti-Mays, so much for this presentation and so much for those wonderful answers to our questions.
Mhm.
And thank you so much to our audience for tuning in to MedNews Week Keynote Conference. Thank you.
Great. Thank you guys for having me. Great. Well, thank you guys
Okay.
so much.
Yeah, absolutely. I do believe